I'm really happy to be here, and thank you all for coming. I love a captive audience. It's basically the reason I became a professor, so any opportunity to talk about exercise is something that I'm happy about. Now, today I'm going to talk a lot about health and wellness. There's a few of you in the room that know that this is particularly interesting since I started this year decidedly unwell. And so I've actually already spent the better part of 2019 reflecting on health and wellness and its importance quite a bit. So I'm going to start with defining health, which might seem like a really obvious thing for us to talk about, the definition of health. I can tell you that if you ask a room full of people to define something that we all think we understand, you get a variety of answers. But most commonly, particularly if I ask undergraduate students to define the word health, they tell me that it's the opposite of being sick, that it's the absence of disease. The World Health Organization actually defines health a little bit differently. So according to the World Health Organization, health is a state of complete physical and mental and social well-being, not merely the absence of disease. And health is often conceptualized on a kind of continuum that I'll show you here. And so on the far end of the continuum, in the worst case scenario, we have mortality. And as we move up the continuum, we have morbidity, or the presence of some type of acute or chronic disease or condition. Once you cross that line, so you're no longer sick, you're not necessarily now considered healthy. And as you move up the continuum, this is when, at the far other end of the continuum, is when you achieve wellness or well-being. So what is this term wellness? If we think about the definition of wellness, there's actually even more variations and interpretations on that term than there is for health. So a quick scan of the internet, and I found the following definition. So this one from the Oxford Dictionary: the state of being in good health, especially as an actively pursued goal. The National Wellness Institute, an active process through which people become aware of and make choices towards a more successful existence. So I found it interesting that a lot of these definitions that I found really emphasize the active pursuit of wellness, and I'm going to come back to that point a little bit later. The World Health Organization, on the other hand, has a bit more to say about wellness. So according to the World Health Organization, wellness is the optimal state of health of individuals and groups, including the realization of the fullest potential of an individual physically, psychologically, socially, spiritually, and economically, and the fulfillment of one's role expectations in the family, community, place of worship, workplace, and just in case we've missed anything, other settings. So I don't think anyone could ever accuse the World Health Organization of being terse or of setting low standards. So this is it. This is all you need to be considered well. So, of course, as was mentioned, I'm an exercise physiologist, and my research interests are around movement behavior and physical activity. So exercise as medicine is what I titled my talk, but just to be clear, exercise as medicine is an actual thing. That's not my catchy title. It's a real thing. It's a global initiative, actually, that originated in the US. And so Bob Salas was the founding chair of Exercise as Medicine in the US, and this is a quote from him that the Exercise as Medicine movement or initiative often uses as their tagline. So what if there was one prescription that could prevent and treat dozens of diseases? Would you prescribe it to your patients? So the goal of the Exercise as Medicine initiative is a lot around primary care and about educating physicians to prescribe exercise for their patients. And so exercise, there is a Canadian branch of EIMC, and the mission statement of EIM Canada is to provide national leadership in promoting physical activity as a chronic disease prevention and management strategy. So the Exercise as Medicine initiative is great, but I'll point out that really the focus here is on chronic disease. So the emphasis is on primary care physicians and chronic disease. So is exercise medicine? This is a question we could ask. Well, there's a reason why this initiative makes sense. We have decades of good data to suggest that physical activity reduces the risk of a whole host of different chronic conditions. So cardiovascular disease, type 2 diabetes, hypertension, dyslipidemia, osteoporosis, some types of cancer, and then of course also all-cause mortality. So obviously, physical activity can really be beneficial from the perspective of health. If money is something that moves you a little more, then we can talk about the cost savings that have been projected from getting Canadians to be more physically active. So this paper in 2014 projected that by simply increasing rates of physical activity in Canada by 1% per year, we'd be looking at more than $2 billion per year in savings. So this is very important work, obviously, and I never want to discount the importance of furthering our understanding of how physical activity can help prevent chronic disease and help manage chronic disease. If we look at some of these, if we think about things like type 2 diabetes, the prevalence rates of type 2 diabetes around the world are increasing at truly astonishing and pretty alarming rates. So this is very important work. But it just happens to not be the work that interests me the most in my research. So I just want to go back to my definition of health and the continuum concept again to explain some of the reasons that I actually have issue with it. So this is how I was taught the concept of health when I was a student, and it's actually the way that I have explained it to many students myself over the years. But as my own research has developed and I've done more work, I've decided that this model of thinking about health actually has a few issues. So if we look closely again at the definition, we can see that health is defined as a state of complete physical, mental, and social well-being, and not only, but certainly including the absence of disease. And if we look at the continuum model, we see that if you happen to be on the left side of that line, so if you do have a chronic disease or a condition that you're working with, then for you, wellness is essentially unachievable in this model. And I think that's actually a really problematic way to think about health and wellness. So Claudia mentioned in my introduction that I'm interested in physical activity and movement behaviors across the lifespan, which is true, but I do have a particular interest and focus on healthy aging and on working with older adults. And so when we think about aging and health, we know that that list of chronic diseases that I've provided for you, the prevalence of those is much higher. It increases with increasing age. And so there are more older adults suffering from those conditions than there are younger adults. But older adults also have a lot of fairly unique health concerns that are also really important to consider. So some of you may or may not be familiar with the concept of geriatric syndromes. So geriatric syndromes is a term that refers, it's a clinical term, but it refers very specifically to non-disease related health outcomes that are very common in older adult populations. So these include things like cognitive impairment, depressive symptoms, urinary incontinence, as well as impaired mobility and falls. And these geriatric syndromes or geriatric specific or relevant health outcomes are really important and have a significant impact on the wellness of older adults. And in fact, perhaps more so than chronic diseases. So this paper from the Health and Retirement Study in the US showed that functional limitations and geriatric syndromes were actually stronger predictors of self-rated health and wellness, as well as 2-year mortality outcomes than the presence of any chronic disease. So these geriatric syndromes are quite important. And there's definitely, in the world of exercise physiology and physical activity research, they're less studied, and they're what actually really interest me. So what do we know about the role of physical activity in some of these issues? Well, those of you in the room that know me know I could never give up an opportunity to make a sales pitch for running, so I will. So this is a study, it's a 21-year longitudinal study. So all of the individuals in this study were 50 years old at baseline, and they followed them for 21 years and monitored mortality outcomes and also monitored disability levels. So the colors have turned out a little odd here, but these pink lines are controls, so these are individuals who were not runners at baseline. And the purple line at the bottom are people who were in a running club at the start of the study. And so they followed them for 21 years and monitored their disability levels. And I think what you can see quite clearly is that the runners over the 20-year course of the study had significantly lower levels of disability. So the conclusion of that study was that vigorous exercise, in this case running, at middle and older age is associated with reduced disability later in life and a significant survival advantage. I didn't show you the mortality data, but the graphs look very similar. But I don't only think or talk about running. I'm also very interested in strength training. And I'm interested in particular in the benefits of strength training, the additional benefits of strength training, even among people who are currently active, perhaps with regular aerobic types of activity. So this is a paper I recently published where some colleagues and I did an analysis of some data from the Canadian longitudinal study on aging. And as I said, my question was, does strength training confer additional benefits to older adults who are already physically active? So the CLSA is a longitudinal study, but only the first wave of data are actually available right now. So we did a cross-sectional analysis for this paper. And what we did is we took the sample there's about 16,000 participants at this point in that study. And about 9,000 of those individuals over the age of 65 reported that they get at least 150 minutes of moderate intensity physical activity a week. So then within that group, I compared people who reported any strength training to those who reported none. And I do mean any strength training. So even if someone said that once a week they do a little bit of strength training, we called them a strength trainer. So very low dose in some cases. And I won't spend a lot of time on the results, but I'll show you some of the significant findings. And so this top box of red, in the red box, these are all functional assessments. So these are functional fitness tests, so tests of balance and tests of mobility. And if you look at the odds ratio, I can show you that we found that the individuals who reported participating in any kind of strength training had significantly higher odds of being in the highest group of scores on those tests. If we look further down, we look specifically at self-perceived health and self-perceived healthy aging. And again, individuals who reported any amount of strength training had an advantage. They were far more likely to have good or excellent perceived health and perceived healthy aging. So remember, this was among a group of healthy, physically active older adults, and this was an additional benefit. So then what's my conclusion? My conclusion is that in order to age well, we all have to be either Ed Whitlock. So if you're not sure who Ed Whitlock is, he's a Canadian running legend. He has passed away in the last couple of years, but he holds world records in age group, world records in running at just about every distance that you can name. And this is Catherine Walter. She's 71, and she's actually currently the captain of the powerlifting club, the women's powerlifting club at Oxford University. So these are our options then to be well. We have to be Ed or we have to be Catherine. Well, no, obviously that's not actually what I think. And it's a good thing that I don't think that, because I would have a very small research participant pool to work with if this is what I was after. Because this represents really, at a population level, like almost nobody. So to drive that point home, I'll just show you quickly some data from the US and Canada. So this is nationally representative data showing what proportion of older adults meet our minimum guidelines for activity. So this would be the equivalent of about a 30-minute brisk walk about 5 days a week. And you can see that the red is the portion meeting that guideline, and it's almost nobody. So very few people, and even fewer older adults than other age groups, are actually getting a lot of physical activity. So then it's important to think about then what all of our other daily movement behaviors and how these might influence our health. So even if you're actually a really active person, moderate and intense exercise still only makes up about 5% of a total day for you. So really, most of us, well, all of us, spend most of our waking hours down here in either what we would call sedentary behaviors, which is what you're all doing right now, and light activity, which is probably what I'm doing right now, sort of standing and pacing. So what do we know about how those movement behaviors, and more specifically the balance between them, and how that can influence some of those geriatric relevant or geriatric specific health outcomes that I mentioned? Well, I'll give you a few examples, and there's less research on this. This is an area that's growing quickly. So in this study, this was a 10-year longitudinal study where they followed a group of older adults and monitored how much time they spend watching TV. And they used, in this example, they used usual walking speed as an outcome. So usual walking speed is actually a very good marker of physical function. And so what you can see, I think, quite clearly from this graph is that individuals who report watching more than 4 hours of TV per day throughout the 10 years. So they averaged the dose of TV time over the 10 years. And you can see that people who watch more TV had a much slower usual walking speed than people who watch less TV. These are some data, Canadian data. So this is an analysis we did of the Canadian Health Measures Survey. So this was about 1,700 men and women between the ages of 60 and 70. And what we were interested in the relationship between sedentary time and particularly the patterns of sedentary time and how those relate to cardiorespiratory fitness. And so if you look here, you can see that we found that individuals who spent more of their time in prolonged bouts of sedentary behavior had lower cardiorespiratory fitness. We also found that breaks in sedentary time, so the number of times in an hour that you just stand up and move a little bit, was also positively associated with cardiorespiratory fitness. So even little bits of movement and breaking up sedentary time was associated with something that is actually a really powerful predictor of health and longevity, cardiorespiratory fitness. And the last example I'll give you, this is also from the Canadian Health Measures Survey, and we looked at sedentary time related to perceived health. So perceived health or self-rated health is a health outcome that I really like and I think is really interesting, but I don't have enough time to talk about it. So maybe we can talk about it later. But what we showed is that individuals who spend more of their time sitting during the day are significantly more likely to have poor or fair self-rated health. And so individuals who sit less are more likely to have excellent perceived health. So then I would argue that maybe exercise as medicine is a little too narrow, and so I've now come up with movement is medicine, which is better because I think it captures the whole picture a little bit better, and also it has alliteration, and everybody likes alliteration. So I'm not sure why they didn't think of that. So then what would my recommendations be based on the evidence and based on my own research on how to achieve wellness? Well, the general sort of broad recommendation to sit less and move more is valuable. We certainly know that increasing moderate to vigorous physical activity is really important to health, and we should not give up on trying to find ways to encourage people to do that more. But we also know that thinking about the lower end of the movement continuum and breaking up prolonged bouts of sedentary time is also beneficial to health. And so if we think about balancing out sedentary time and that light physical activity, we know that if light physical activity outweighs sedentary time, it's associated with positive health outcomes. And this is particularly true in people who aren't actually very physically active. So this might be a particularly important strategy for older adults. So then sit less and move more. It sounds really simple. So what then is the best strategy to achieve this? I don't actually have a lot of time to talk about this, but I did want to mention just a couple of points about what a couple of my thoughts on this particular issue. So one question that people often ask me then is this the answer? We all need standing desks. So I'm going to start by saying I have a standing desk and I love my standing desk, and I have a standing desk at home and at work, and I think they have a lot of benefits. But I also think this is a very classically human approach to a problem. Like, oh, I heard that if you sit too much, it's bad for you, so I'll get a standing desk and I will now stand all the time. Like this, there is no way that this is the solution. More is not better. That is rarely the solution, but it does tend to be what we think. So I don't think standing desks are the solution, although I think they have a role to play. So a lot of our strategies around encouraging more movement and encouraging more physical activity at a population level, which hopefully I've convinced you is a really important thing that we need to do for population health, are very focused on the individual, right? Standing desks, and we need to motivate people, and we need to get people to go to the gym. And I'll draw your attention back to that definition of wellness. And you'll recall that I said, I think it's interesting that all these definitions of wellness really emphasize this actively pursued goal. It's not wellness until you're trying hard to achieve wellness. And the truth is that at this point, we already know that all of these strategies focused on the individual are not effective on their own. So if we want any of the individual level strategies that we come up with to have a long-term effect, we need to think more about the environment around us. So we need to think more from a social and ecological perspective. So the social ecological model suggests that there are actually multiple levels that influence our daily behavior, all of our behaviors, including our movement behavior. And so if we want individual level change to actually have a long-term effect, we also need changes at other levels. In our social and our built environment, we need to ensure that there are changes that, in the case of older adults, that provide opportunities and accessibility for people to access things other than prolonged periods of sitting. So I'm right on time. I'm going to end with a different definition of health, and one that is certainly much shorter than the World Health Organization definition, and one that I quite like from Dietrich Bonhoeffer, which is health is the strength to be. And so I will leave it there and turn it over to my colleague.